So next on, we have Aneesh Chopra, who will be leading us in talking about how public-private organizations come together. And we're just gonna connect Aneesh now. So Aneesh, are you able to share your video?
Not video. Yeah, I got.
Okay, you're gonna present something.
Yeah, if that's okay. And let me see if you can. You all see my slides?
Yep, we can see and hear you.
Okay, great. And so, first of all, Ricky, thank you for that. I enjoyed the discussion you had with Don Rucker, and I'm, as you could imagine, thrilled with the opportunity that this regulatory action presents for the industry. For those of us who are in the what I refer to as a religious movement, that we can actually deliver a healthcare system that is better at lower cost. This gives us the much needed digital foundation to do the critical work that needs to be done. So, Ricky, what I thought I might do is summarize my take on the rules, to put them in context, and then to share a bit more on the implications for the audience. So I'm going to do this as an act in three parts: the context, my implications, and then knowing that we're only, whatever it is, 48 hours since the publication of these things, acknowledging this is a first cut, not a complete review, but my initial take on recommendations for folks on the payer side, the provider side, and other stakeholders who are looking to not wait for the end of these timelines, but want to get started now, which I think is critical. Ricky, just to kind of set the stage for the conversation, because I served as Chief Technology Officer, which was broader than healthcare, I thought I'd bring a little bit of the macro environment to this discussion. We remain in a bipartisan frenzy of driving healthcare inflation to some kind of rational constraint. If we can get healthcare inflation to GDP plus zero, this does free up a significant amount of capital that can be reinvested in areas of greater stress for the global competitiveness agenda. Obviously, we're dealing with COVID right now, which is more of a sort of defensive posture, public health need. But the broader question about American leadership in the global economy for the next generation, that's a great deal of interest to a number of folks on both sides of the aisle. And unless we're going to dramatically expand the size of government, we're going to have to optimize the resources within. And there is a group of us, and I call this the religious movement, that do believe that we can, in fact, constrain some of that healthcare inflation, not by rationing access or constraining or capping prices, but rather by delivering better care. With one obvious exception: on the commercial market, prices clearly need to have some rationality, but at least on the government-sponsored side, we can do a lot on delivery reform. The model for those in this movement really follows that we hopefully benefit from more open data sets, so we have situational awareness about what's working and what's not in the delivery system, that we can adjust the payment models to incentivize better care, and ideally that we route people more thoughtfully through the delivery system with their agency, in the form of what Don said at the end of his remarks, the empowering of the American people with tools on price and quality, but also in these sort of accountable care models where your primary care doctor acts as a quarterback with you in that journey. Either way, the principle here is by opening up the data, by adjusting the incentive models, we should be able to personalize individuals' navigation through the system to result in that better care at lower cost. Because of, again, the context here is my time in government, there had been an important foundational piece before we get to the interoperability regulations that we should open up government data as core infrastructure. And probably chief among the assets that are important to open up had been the Medicare and Medicaid and other government coordinated data assets. Obviously, we'd love to see all health data accessible. That's a broader debate about all payer claims databases and the like. But for now, we're benefiting from a bipartisan commitment to open up government data. I don't want to spend too much on this slide, but I do find it interesting. When the Obama administration released the Medicare data down to the physician level, Wall Street Journal and other media companies rapidly deployed websites. This is a screenshot from the still online, the Wall Street Journal sort of find a doc, dialing for doc, whatever the name of the title was. This is the highest paid doctor Medicare paid in 2015. I've, out of discretion, blocked the names, but it's public data. The doctor was paid $11.1 million, and the majority of that reimbursement was tied to the administration of drugs that were administered in the practice. In this case, an injection to help delay the onset of blindness. So one might say, well, that's the healthcare system we're in. But what you may not know is that this particular mix of medications that this doctor chose to use were more of the variety that were priced at $2,500 an injection, or perhaps $3,500 an injection, when the NIH had noted a $50 clinically equivalent alternative is available in the marketplace. And so if you were to benchmark this particular physician's choice of medications to treat a comparable condition against others that might have a different point of view, the results might be for similar or better quality, dramatically lower cost. Again, as a brief infomercial about what I do for a living today, Care Journey, we are building those physician level profiles on account of access to the Medicare data, not on the public files, but as a researcher approved for detailed access to the underlying information. And so you'll start to see, not just from us, obviously, but a growing volume of partners, public and private sector, really pushing out the transparency agenda on open data. Now, having said that, there are 5 things that I think are critical to move beyond the aggregate open data movement, but around this interoperability menu of regulations. And I've identified 5 that I think are top of mind for folks that have to make decisions in the near term about implementation. My first statement here, and this is a bit of an interesting one given the handoff between the Obama administration and the Trump administration, payers were largely, I wouldn't say sidelines, that's not the right term, but they were not directly involved in the meaningful use program. We were encouraging payers to help reward doctors who became meaningful users, and there was a lot of collaboration and public input about what the meaningful use rules should be. So I don't mean to suggest that there hadn't been participation, but this is the moment when payers actually have to deliver their own content in a FHIR server. That is new. There was no meaningful use framework for health plans. That is here, and more to the point, it's here first. The rules that Don Rucker mentioned have a 2-year, or in some cases 3-year implementation timeline. Payers have to go live by 1/1/21. And so we'll talk a bit about the implications of payers having to, quote unquote, go first on the new FHIR R4 standards. Pretty exciting, actually, and I'll get into that in a moment. Second, there's an opportunity to engage with the extension of these consumer-facing API standards into the bulk use cases. There's no regulatory requirement to actually open up bulk access to anybody, but as Don very thoughtfully pointed out in his remarks, we now have a requirement that the infrastructure has to be available if, by contract or other means, parties agree to share data. This should at least reduce the burden on how they share that same FHIR payload, but for a population level cut rather than a single patient at a time. There'll be a healthy debate around all data elements. EHI export is the provision. You heard a compromise in the final rules that allows app developers, EHR developers to negotiate intellectual property protections or licensing arrangements for the broader data set. But there is plenty of room of opportunity for the industry to self-organize around a standards-based, hopefully FHIR-based option. We'll have to grapple with privacy in a manner that goes beyond the minimum necessary, and we'll hear a bit about that in a moment. And then last but not least, I think there's been a great deal of, it's like a kid in a candy store, a litany of other additional data sets that are going to be helpful beyond the PHI that is at the heart of the interoperability regs. So let's dive into each of these, Ricky, at a respective time for questions, if that is appropriate. First, my view is that the health plans that are going to go first will actually be a significant demand signal towards the adoption of not just the their own FHIR server, but the source data to feed into the stuff that they have to make available, the US CDI, that they'll put pressure on providers to make the source data available in a kind of a native FHIR format to ease their implementation burden. So again, a quick reminder, health plans are going to have to deliver their claims data, and for whatever universe of patients where they've collected the full clinical data set, maybe the patients for whom they've done HEDIS measures or others, that they have to provide that information back to the consumer designated apps by 1/1/21. I love reading the preamble or the content around in the final reg text. It gives you some of the background and the debate that was taking place. CMS noted the following, which I thought was really powerful. There will be downstream impacts from the patient access API requirements on the relationship between payers and their contracted healthcare providers. It will be up to each payer's discretion to address whether this information needs to be included in contracts with providers. In other words, Ricky, I think this is a watershed moment for health plans to play a pretty significant demand signal role in encouraging providers to be early adopters of the ONC requirements. And so just to kind of give you the timelines here, the EHR vendors have largely agreed on the technical standards for what meets the US CDI over FHIR requirements. For wonky purposes, we'll call that the Argonaut Project R4 updates that folded into the US core standards, okay? So that specification, the implementation guide, has been endorsed and published, I think, since the fall. Now, it does allow for 2 years of adoption, but that doesn't mean that providers wouldn't be asking to go first or early. So there may be, in the form of a demand signal, health plans beginning to exert pressure to suggest to their providers, at least those that are willing and capable of doing so, to offer this payload that is US CDI R4 compliant to meet the 1/1/21 goal for the plans that have to ultimately publish it to the consumer. So this may be a two-hopper in terms of demand signal, which gets me pretty excited. The ability to extend these FHIR capabilities for bulk applications, again, in July, or I should say August of last year, actually it was July, Blue Button Developer Conference, a number of stakeholders, a dozen or so plans, a dozen or so health systems, stood on stage and said that they were ready to real-world test the FHIR bulk standard, which takes that population level view Don just described. And already organizations like Rush and Jefferson and others have begun deploying bulk FHIR apps. This Jefferson app is a mock-up of what they'll be doing, tapping into the CMS data at the point of care application as an example. Like in this example, broadly, CMS is going first, not just on the consumer API via Blue Button 2.0, but in this case, by deploying a production-ready version of bulk FHIR, both to physicians in the form of data at the point of care and to ACO networks through a program they're running on it's called the Beneficiary Claims Data, BCDA. The EHI export is what I consider to be a Roku moment for healthcare. I was trying to figure out the right analogy, which is that the common clinical data set back from 2015 had the data elements that you see on the left. Frankly, and this is a bit of my challenge, the frustration that we've seen, wearing my former government hat and now private sector hat, we as an industry really haven't added a lot of data elements voluntarily to the common clinical data set since it was initially published in January of 2010. With the US CDI, the industry is forced to add open notes and a few other items, but basically whatever the government minimally requires is what is publicly accessible using these sort of FHIR API open data standards. The Roku moment is that while there is a content and manner provision for the EHR developers to negotiate their own deals with respect to the larger payload for EHI export, I am hopeful, and in fact, hoping on this call to recruit as many stakeholders in the industry as possible to think about what a FHIR-based option would look like that's intellectual property free, built on open standards, to be able to represent all of the channels of content that we would otherwise expect to see in an EHI export. And so I think of those as Roku channels, a channel for the care plan, a channel for discharge notifications, a channel for pricing, a channel for imaging that may or may not be specifically in US CDI, but might appear in the EHI export. So could we, while the vendors work on negotiating their IP rights, could we work as a community on an alternative? I'm riffing through, Ricky, so we get some context for questions, but just to acknowledge the statement about privacy, as many of you on this call know, I'm involved in the Karen Alliance. The Karen Alliance has spent the last 2 years working in a multi-stakeholder fashion to build a code of conduct. That code of conduct extends beyond HIPAA in areas such as the right to be forgotten. And as I put on the graphic, areas where we're disclosing in the Karen Code of Conduct, the app developers will, what their privacy policy is with respect to de-identified data, a topic that is not required for disclosure under HIPAA and was part and parcel of this whole melee around the Google Ascension article and a variety of other areas where people are wondering, why is that not something the industry is required to talk about? It appears to be one of those gaps that we're going to likely close. So now the question is, if in fact we have the ability in the rule to, I wouldn't use the word discriminate, but establish a standard. If you're a health plan or a provider and you want to say, look, certain apps may be riskier than others, it could be the case that the industry can sort of reaches consensus, whether it be the Karen Code or others, to say, look, if you publish your policies around these issues comprehensively, then you'll be deemed a quote unquote a reasonable consumer app. But if you don't disclose this information, we're going to put the skull and crossbones warning like you get when you visit a quote unquote shady website. The browsers have all agreed to put that skull and crossbones like signal. When it doesn't prevent you from going to that website, you can still click through and find your way to the website. So it doesn't remove your rights, but it hopefully gives you a lot more warning that you're about to enter uncharted waters. So I do hope that the way the final rule was written will result in industry consensus around a set of principles that app developers should be held accountable for. And I'm hopeful that this is not seen as a sort of big tech, evil sort of app developer, hackers, kind of building these consumer apps, but quite the opposite. On the right, you could see a survey by Rock Health. Who are consumers willing to share their health data with? Look at the top of that list. They're HIPAA-covered entities. My physician, my health plan, my pharmacy. They far exceed trust from quote unquote big tech, as you can see at the bottom. So I'm actually expecting HIPAA-covered entities to build consumer-facing apps. In fact, I'm encouraging and hopeful that they will, and that many of them will take those same privacy protections and extend them into their HIPAA-covered entity land. So we'll have a higher level protection across the board and not a certain standard for HIPAA and a certain standard for not HIPAA. A few more slides, Ricky, and then we can have a conversation. One, I think all of these 5 principles raise the question, if I were a health plan or a health system today, probably first step would be to get my arms around data governance. Let me map all of the source data sets that are going to be required for me to publish to the consumer-facing apps. Internally to a health plan, you might have a separate server for your medical claims, a separate server for your PBM, a separate server for mental health and the behavioral health carve-out. You may be tapping into lab values through intermediaries or HIEs. You might pull EHR data directly through any number of mechanisms. How do you think about all of these sources that come into your data environment, organize them at the patient level, and then present a common payload to consumer trusted apps? That's going to be a lot of work. And so my recommendation is get your data governance teams up and running immediately. Establish your API strategy so you can establish the rules of your marketplace, and then begin mapping each of these source systems. In my opinion, I'd take one source end to end so you can actually demonstrate that if you just got one, the medical claims, you can deliver that before you add the other content channels. But you'll all come to your own conclusions as we proceed during this year of implementation. I do think we should be like CMS, which is to say the recommendations coming out of CMS is that parallel processing might actually ease the implementation burden. The consumer-facing requirements have to go first, like Blue Button 2.0. But if you build Blue Button 2.0 infrastructure at the same time as your bulk infrastructure, you might get some economies of scale. You can see that at CMS, and I love that they named it this, their bulk FHIR server, or BFD, is feeding consumer apps, physician apps, and those ACO network apps, and actually feeding their health plan apps who are part of the Part D program that have the ability to access their Part A and B claims data simultaneously. So parallel the implementation of bulk and consumer to get the administrative savings and to open up more use cases. I do believe we're going to be entering this era of substitutable apps. We'll talk a bit more about that later. Final statement, I think the rise of what I hope will be a new market category, a category called a health information fiduciary. That'll be a subset of these consumer apps that pledge not only to keep your data secure and to protect your privacy, but might go further to say that all of the decision support we're going to render for you will be in your best interests, akin to a financial services fiduciary. In doing so, the ability to route patients to more cost-effective, high-quality service providers, as an example, might now be a rewarded consumer-facing app. In a separate rule, CMS has put out the proposed transparency rule. They've actually offered that if you want to build apps for consumers that give them a gain-sharing payment if they choose a lower cost, higher value option, that those gain-sharing payments can actually count against the medical loss ratio, which is a bit wonky speak to say there's a financial incentive now to put apps in the hands of consumers to more thoughtfully navigate through the healthcare delivery system. And I can't wait to see what that new class of app developers building these fiduciary apps looks like. Ricky, I will stop there and I will turn, if you have a few minutes left that you want to get into any kind of conversation to do so.
Yeah, for sure. Yeah, so thanks a lot, Aneesh, to take us through this. We have some questions from our YouTube channel. So what advice would you give the audience today on how to work with these new standards-based approach over the next few years?
Yeah, so herein lies, look in the mirror. Are you going to do minimum necessary for compliance? Or are you going to embrace this moment to think about what's in the best interests of the consumers you serve? And if it's the latter, then you could envision any of the following. One, you could envision proactively building applications that consumers trust. You could think about this as dog fooding your compliance requirements. So if you're a payer or a provider and you're going to have to produce this feed to third-party apps, you might consider building one of those apps, at least as a skunkworks project. And if you don't have the development resources, maybe partner with a few. But the premise being, what would you do if you earned the consumer's trust to aggregate their records? What advice would you offer them as they navigate through the delivery system? Thinking about that, if you look in the mirror and say, that's who we are as an organization, I think I would view that as sort of strategic judgment number one. Are you or are you not a health information fiduciary? And do you want to embrace this compliance era with a grab the bull by the horns, if you will, to support that? There is, for those of you who are on the compliance mindset, like, hey, that's not me. All I do, I'm a hospital. I just want to treat you well. I'm going to get you in, get you out, get paid fairly for what I do. God bless America. There's plenty of room for that in the system. You might want to think about efficiency. And that's where I get into this conversation of a bulk plus consumer feels like the more efficient path to give you the option value for not only what the government's going to mandate, but how your payer partners and your pharmacy partners and your other stakeholders are going to want to interact with you. So that would be my advice. Figure out what your strategy is, and then think about the efficient deployment of these standards in totality.
Awesome. And then another question from Josh. Do you expect any pushback on the 2021 date for the patient access APIs? And then what are you thinking the provider directory API requirements may be used for in the near future?
Great. Look, Seema Verma gave a speech at HIMSS in 2018. That's 2 years ago, where she said effectively, government-sponsored plans, I'm expecting you to copy me on Blue Button 2.0. She wrote it specifically in an op-ed in May of 2018, if you didn't hear the words. So the industry's had 2 years to prepare for the regulation and clearly got the message in the proposed rule that they were going to ask you to go live by 1/1/20. Now, I did enjoy reading the litany of comment letters that sounded akin to, woe is me, this is hard, I can't do it, please give me 2 or 3 years to implement. And I think in the final rule, you're hearing the administrators say that enough is enough. We can't simply wait for a regulation to do the right thing. We should have been working on these things all along. So no, I don't think there are going to be people complaining about the timeline, but I think we're going to have to execute. And I hope the vast majority of the folks listening to this webinar and others in boardrooms all around the country will say, look, we just got to do this. You know, this is the right thing to do for the patient, number one. And number two, the government's taking this pretty seriously. And so that's how I see the deadline. I do hope and expect that we'll hear a lot more from CMS on ways to open source every single thing that they've done, so you can copy that infrastructure and not start from scratch. So this is not a, good luck. This is let's all hands on deck this thing. And I think it'll be in the spirit of open source and collaboration. As to the provider directory APIs, for sure, I'm hopeful this will result in the infrastructure, if you will, for smarter physician navigation services for patients. So not only do I want to be able to find a doc, but I want to find the right doc for me that is based on sort of this information. And I want to be able to access the digital endpoints of that doc and the information about whether they're seeing new patients from my plan and otherwise. That's been woefully inadequate. These directories are terrible. And so we're going to see much greater data quality on the physician directory side on account of these rules. And it'll be open data for all developers to access and use.
Awesome. And the last question from Eric, is there any industry support or opinion for the skull and crossbones signaling you described? And how do you think it will be received by the existing players in the space?
I can speak for the Karen Alliance conversations, and we are absolutely focused on driving the adoption of the code of conduct, and by any means necessary. And so there's work underway on what a nutrition label looks like. So rather than a 30-page user agreement that nobody reads on the privacy policy, that we have icons akin to the nutrition label in the supermarket. And so there'll be work to standardize the infographics on privacy, and I hope work on the skull and crossbones now that there's been clear signal from the regulators that we're allowed to do that. So that's one vehicle. Please join the Karen Alliance, KarenAlliance.com website. It's all open collaboration model. And I'll show up to any venue that wants to get into these issues, because we're going to have to manage some of these privacy risks from the public-private perspective, as opposed to waiting for some national privacy law, which may not happen anytime soon.
Awesome. Thanks a lot, Aneesh.